Good evening, everyone. We will start the session now. I invite IASO President Dr. Subrameshwar Rao sir to welcome you.
Sir, good evening.
Good evening, sir.
Good evening. No, I think it's a proud privilege to be welcoming the faculty, the participants, the examinees, and all the ISO members and students. Now today we have a session on stomach cancer. We have 3 examiners. Hemant Udayaraju, I had the fortune of working with him for quite some time, and I've seen him grow into a terrific surgical oncologist, a complete all-round surgical oncologist. He would be the examiner for the session. And then we have Pankaj Garg, Professor and Head Department of Surgical Oncology, Sri Mahant Indiresh Hospital and Sri Guru Ram Rai Institute of Medical and Health Sciences, Dehradun. Once again, an excellent academician, a very prolific writer, and he's somebody who has changed the direction and changed the gear of IASO as a journal. I think it has grown to a very great heights because of his leadership. And we have him delivering the expert talk. And then we have the energetic Meera Wag, who has worked on the case capsules here. She's an additional professor, Division of GI and Thoracic Services at the famous Regional Cancer Center, Trivandrum. She would be moderating the session. Welcome, welcome Hemant, Pankaj, and Meera. And good to have you all here. I'm sure you will teach us and see that we learn a lot. Thank you.
Thank you,
sir.
sir.
It's really my privilege.
Now, just confirming once, do we have both our examinees with us?
Hello, ma'am. Can you hear me, ma'am?
I can hear you. Can you please introduce yourself? Dr. Ashish Naik. Yeah.
Good evening, everyone. I'm Dr. Ashish Naik. I'm a third-year surgical onco resident in KLE, Belgavi.
Okay. Dr. Sharada.
Good evening, everyone. I am Dr. Bhavna. I am from Adyar Cancer Institute, Chennai. I am a third-year resident here. Thank you.
Okay, great. So just small housekeeping rules for both the candidates. Please try to answer to the point, and you are not required to know all the answers. There is no harm in mentioning that you do not know the answer. We can provide you with clues and answers and move on. It saves time and maintains the flow. Examiners keep dropping hints all the time, so it's important to keep an open mind and try to catch those hints. For our examiners, in the interest of online viewers, please give the expected answers to the questions that are either unanswered or answered incorrectly. And whenever you are asking the questions, kindly direct the questions to each of the candidates by name. That will ensure that both of them get equal opportunity and we do not waste time. For the rest of the participants, kindly try to participate actively through the online chat box. With this, I hand over to Dr. Meera. You can take the discussion forward.
Thank you. I will share my slides. Please feel free to interrupt any time to ask questions or any doubts.
Sure.
Are my slides visible?
Yes, madam.
So we move on to the first case. It's a 61-year-old lady, homemaker from Kottayam, presented with complaints of upper abdominal discomfort for 3 months, vomiting for 2 months, unintentional weight loss, 7 kgs in the past 2 months. She lost her weight from 58 kgs to she's 51 now. History of presenting illness, upper abdominal discomfort and bloating after food, which is relieved with burping or vomiting. This has been there for the past 2 months. She has been taking only liquid diet for the past 15 days. Since then, she has only occasional vomiting and reduced discomfort. Dr. Ashish, would you like to know more about, like, what would you like to ask more in history of presenting illness?
Whether patient has vomiting, associated vomiting with the above complaints, whether there are any undigested food particles which are there, whether there is any hematemesis associated, whether there is any
History of vomiting is there already. So
So
regarding vomiting,
hematemesis, I would like to ask, and I would like to ask vomiting, what kind of nature it is, how much volume after food, how much immediate duration of vomiting, immediately after taking meal, or it is after a period of duration, 2 to 3 hours or 24 hours. What is the duration? And nature of vomiting, quantity of vomiting, I would like to ask.
anything else, Dr. Bhavna?
Ma'am, I would like to ask history of Malina. Either bleeding history is there, history of hematemesis, same history. Whether the patient is having outlet obstruction history, like whether the vomiting quantity, the duration, is it after immediately after consumption of food, or whether it is after some time, like just to find the location of the tumor.
Dr.
Whether-
Ashish,
You are
So-
assuming
Yes,
it's a
sir.
tumor.
yeah, so you said that you will find out the time frame of vomiting. So you said 2 hours, 24 hours and all. So what exactly are you looking for? So what does it convey? Which time frame conveys what clues towards your diagnosis? You said immediate, 2 hours. How does it help you with your diagnosis?
Sir, it will tell us whether the patient has a gastric outlet obstruction, and whether it is proximal or distal, whether the capacity, is it a kind of diffuse linitis plastica, where the volume or capacity of distensibility of the stomach is reduced, so that in those cases the vomiting would be early.
So what would the typical vomitus of a gastric outlet obstruction be, the time frames? The patient has food in the morning, so when do you expect? Does it go on 24 hours, or what is it usually like?
Yeah, usually 24 hours duration, sir. After that, he will have a undigested, foul-smelling, non-bilious vomiting if the patient has gastric outlet obstruction.
Please go on.
We can also ask metastatic history, ma'am, like whether there is back pain, whether he's having jaundice, to check whether it is an
You're
advanced
assuming it's a, you're assuming it's a malignancy.
malignancy, but whether it
Previous history of gastric peptic retrosternal burning sensation, discomfort, that also has to be added. Whether the patient is on chronic PPIs, proton pump inhibitors, which will add on to help you to comment about whether he's a known case of acid peptic disease.
So this lady had a non-projectile, non-bilious vomiting containing undigested food particles from previous day, foul smelling, and the vomit is led to temporary relief of discomfort. So this is the negative history. Coming to past history, she is a hypertensive, diagnosed 2 years ago on regular treatment. Hepatitis B positive, on medication for the past 5 years. No history of acid peptic disease. History of vaginal hysterectomy 20 years ago for fibroid. Personal history, diet is mixed, appetite is present, but she can't take enough food because of fear of vomiting. Reduced frequency of bowel movements, no bladder complaints, no substance abuse. She's para 2, history of transvaginal hysterectomy 20 years ago, no family history of malignancy. So, Dr. Bhavna, could you summarize the history and give possible diagnosis?
She's a 53-year-old lady, 43-year-old lady with complaints of abdominal discomfort and bloating sensation and vomiting with a history of homemaker by occupation with history of loss of weight and loss of appetite. Significant loss of weight and loss of appetite. She has lost.
Appetite is there.
Appetite is there, but loss of weight.
Dr. Ashish, would you like to improvise? Dr. Ashish, would you like to improvise on it?
What is the age of the patient? She's
61.
60. Okay. So history of medication, is it relevant here? Patient
So
seems to
without
have-
any significant family and past history, and hello, sir. Pardon, sir.
The patient seems to have some significant medical history here in terms of hepatitis, right? Does it have any bearing on the
Yes, sir.
possible treatment that we are going to consider for the patient? She is on treatment, is
Sorry,
it?
sir.
Am I audible?
Yes,
Sir,
sir.
patient is hepatitis B positive. We might
Yes, sir. Yes, sir.
have to do procedures for her. Like we might have to do endoscopy, we might have to do surgery based upon the diagnosis. We don't have a confirmed diagnosis yet.
Okay.
So
is there
we will-
anything else that you would want to ask? You said that you're thinking in terms of malignancy. You're probably right? In my time, if there was a gastric outlet obstruction, the causes were something else, right? So what proportion of gastric outlet obstruction that we are looking at here, obviously, would, what are the common causes of gastric outlet obstruction? Let us put malignancy or non-malignant causes. What is more common as on today?
Non-malignant, sir.
Really?
Non-malignant. Mostly it is secondary to duodenal.
No, as on today.
Non-malignant.
Okay, I'll let me reframe the question.
Post-peptic ulcer.
So which is more common? Post-peptic ulcer today is more common, or malignant causes are more common?
Nowadays, in today's scenario, sir, it is secondary to malignancy.
Correct. Yeah.
Because of pump inhibitors, the rate of peptic ulcer disease as well as the strictures have been reduced, and it is more commonly now secondary to malignancies, usually the distal located.
Okay, so what proportion probably would be as on today malignant versus what is probably non-malignant? If there are 100 cases, how many probably would be caused by a malignant GO1? The rest of the other benign causes.
Take a while, yes.
Yeah, in our time, I'll tell you the
Sorry.
answer. In our time, when I was a MS resident, it used to be, somewhere around 60-40 benign to malignant. Now it's the other way around. It's probably 70 malignant and 30 benign. That is how much the picture has evolved in the last 15 to 20 years, just to give you a perspective. So if you're thinking about malignancy in this case, straight away, you're probably not wrong, right? Now, just to give you a perspective, I just wanted to tell you. Yeah, please go on.
So Dr. Bhavna, would you like to, when asked in exam, would you like to summarize in a single clean sentence about the summarize and give a possible diagnosis?
So it's a 61-year-old
Take
lady.
a minute and yeah.
So she's a 61-year-old lady with complaints of abdominal discomfort, bloating, and vomiting with significant loss of weight, probably due to gastric outlet obstruction, most commonly due to malignancy.
Dr. Sharda.
Yeah.
Dr. Sharda, can I ask you something? So you said it's a gastric outlet obstruction, malignant. So what are the causes of gastric outlet obstruction, likely causes in this patient?
So considering her age, which is 61, and considering the duration of the symptoms, And knowing that by her history, that she has no previous episodes of acid peptic disease, I would put malignancy as the first cause.
No, I agree with your point. I'm just asking what are the likely malignant causes. I agree your point. Dr. Hemant has already elaborated on this. We hardly see any post-peptic stenosis cases now. Those were the days when we were resident, things were different. Okay, so now the scenario has changed completely. I completely agree. So what are the likely malignant causes? This is what I'm asking.
I'll give you a clue. Sir is asking that what else are you thinking other than stomach? Am I right, sir?
Exactly.
Yeah. So CS stomach, we all know it. What are the other malignant causes which you can think of in terms of GO here?
Sir, it could be pancreatic head mass large enough to cause compression.
Exactly. One.
Then it could be D2 duodenal adenocarcinoma also. Ampulla of water, there could be periampullary, it could be a duodenal carcinoma, which could cause.
Third.
Okay, next.
You are in Adyar. I think one of the malignancy which is very common in this gangetic belt that can cause gastric outlet obstruction.
Something from the surroundings of not exactly luminal, but from the neighboring organs. Sir has already given you a clue.
This gangetic belt, especially where I work.
GBC.
Gallbladder cancer. Yes. 3.
Gallbladder cancer can cause.
4.
Any large retroperitoneal sarcoma, large lesion, large enough to compress the.
Correct. 5th. You see, anatomy is always a friend to a surgeon. So think of the structures that are there in that vicinity. And only those, when can enlarge, can cause gastric outlet obstruction. So you have rightly said there is a gallbladder which can cause, there is a pancreas which can cause, duodenum, there is a retroperitoneal things. What else which is very common there?
Okay. Sir, renal mass.
Can enlarged lymph nodes cause that?
Enlarged lymph nodes can also cause.
So always have do not have a tubular vision. Think of so many possibilities. It is just not CA stomach. So I completely agree. We all agree that it's a gastric outlet obstruction, mechanical, likely malignant, and can have so many etiologies. Okay.
Dr. Ashish is.
Yeah, we'll move on.
Please go ahead, Dr. Meera.
Is Dr. Ashish still with us?
Yes, ma'am. Am I audible?
Yeah. So sorry.
Yes, Dr. Ashish, you are audible.
Am I audible, ma'am?
Yes, Dr. Ashish, you are audible.
Sir, go ahead. You were asking.
Yeah. So, Dr. Ashish, now how will you proceed? So, examination, I think Dr. will be presenting the examination. Or any other question. And then the Hemant sir was asking very relevant question about your medical history, which is very important in this patient.
Hepatitis B.
Hepatitis B. So what
patient on hepatitis B, liver cirrhosis, gastric varices, portal hypertension, and patient.
How that portal hypertension and varices will cause obstruction?
No. Cirrhosis.
Correct. Next.
No, sir. It's.
It is just a comorbid condition. I'm just trying to correlate things. That can there be something which can cause obstruction in this?
I can't understand, sir.
What I am asking,
Nodes,
history of hepatitis B,
hepatoduodenal nodes which can be there.
So it could be a hepatocellular carcinoma with nodes compressing. So always have your mind open.
Hepatocellular carcinoma.
Dr. Ashish is not clearly audible. I think his connection is not stable.
Hepatoduodenal nodes.
I got your
external
point.
compression can be there.
I got your point. So gastric outlet obstruction, there could be an intraluminal, as we used to study during our MBBS days. There could be luminal in the wall and outside the wall.
Shall we move to the examination?
Exactly.
Okay.
Extra
So
linear.
she's poorly nourished, BMI of 18.3, mild pallor. Other than that, nothing significant in general physical examination. ECOG 2, epigastric fullness is present. Then there is succussion splash heard. On ausculto percussion, dilated stomach is seen. When she drinks water, there is visible gastric peristalsis, no free fluid in the abdomen. Per vaginal, per digital rectal examination, nothing specific, no deposits, no adnexal masses. Systemic examination is normal.
Connect from my phone.
Yeah. So, what exactly would you look for in the systemic examination in this particular case?
Sir, we'll start from the general physical examination. We will look for the performance status, as ma'am has said, and the nourishment status we will see. We will check for dehydration additionally because she's having vomiting and so we will look for that. Then we will look for supraclavicular node and
Dr. Sharda, what is the difference between built and nourishment?
sir,
We have written moderately built and poorly nourished. So what is the difference in between these two?
sir, nourishment status is the built is like built is based upon the structure, like moderately built and
Yes,
poorly
exactly.
built.
You are correct. So
That
built is
structure
nothing
of
but
the
the
patient.
skeletal framework. We can have a
Skeletal
tall, we
BMI,
can have
huh?
a short, we can have an
Yes, sir.
average.
Yes.
That depends upon the race
Yes,
of
sir.
the person. Okay.
Yes.
Nourishment is muscle
The
mass.
muscle mass, basically
Yeah, exactly.
based upon the.
Please go ahead.
Yeah, we'll go on.
Then we look for the supraclavicular nodes. We will check, sir, upfront. Then dehydration will check. Pallor we'll check. Then then after examination we will check for abdomen examination. We will check if there is any mass per abdomen. If there inspection we will check, sir. Inspection will check if there is any visible fullness. There is epigastric fullness in this patient. Then we will look for if there is any visible gastric peristalsis. Then either there is any nodule in the umbilicus. We will check for that, sir. Then palpation will again palpate if there is any mass palpable in the abdomen per se. Then we can look for gastric distension. Then
Okay, we'll just move ahead. This lady has already had a hysterectomy, right?
yes, sir.
So what are you looking for in PV here? Normally in any other lady with this and this particular lady who's had a hysterectomy, what clues do you get towards an advanced disease?
Sir, we will palpate for any deposits, sir. We will look for Blummer shelf deposit, whether it is there. It indicates there is advanced peritoneal disease.
Okay, good.
So.
And what else? She's had a hysterectomy. Assume that her ovaries are out.
Okay. So we will look for if there is any pelvic mass also. For Krukenberg tumor, deposit can be there because of the if I'm suspecting CA stomach, so I look for if there is any ovarian mass.
Whatever. We are thinking of an advanced malignancy.
Advanced malignancy.
It can be anything other, not only
three
stomach.
things.
Yeah, it could be pelvic mass. We will look for a pelvic mass, sir.
No, what three signs are you looking in a pervaginal examination? One, ovary, Krukenberg, you said possibly ovary is out, right?
Okay, sir. Yes,
second
sir.
is Blummer shelf, and third
Blummer
is
shelf
what else? What else?
Malina, we can PV, yes, sir. PV or
PV. Difficult, but you can elicit ascites there. It's difficult, but
ascites. Okay. Okay, sir.
By the way, do you know who was Krukenberg? Anyways, we'll answer it in the. It's got nothing to do with this. He was an ophthalmologist. Okay, yeah, please go on.
So what do you want to do next?
Ma'am, I will look for, I will first do a blood panel containing hemoglobin level. I will check for the electrolyte level, then renal function tests.
Okay, electrolytes, what do you expect in this particular patient? You said the patient has had vomitings for quite some time now.
Sir, I will look for GOO. There will be electrolyte imbalance, sir.
Yeah, what exactly?
Hypokalemic, hypochloremic, metabolic alkalosis.
Okay, right, fine, good. That's it. Yeah.
With paradoxical aciduria.
Right. Okay.
So I will check for electrolyte imbalance. Then hemoglobin level I will check, sir, because she might be having pallor is there. She's having persistent vomiting. LFT I will check. I'll check albumin. But if there is any derangement, I'll check. So then after routine blood workup, I will diagnostic investigation. I'll check for any endoscopy, sir.
Would you optimize the patient first?
Would you optimize the patient first? Yes,
Would you
sir.
optimize the patient first?
You want to do endoscopy first here or imaging first here?
Sir, we'll do an endoscopy.
Dr. Sharda, don't get confused. Suppose you are sitting in OPD, you must have seen so many patients like this. A patient comes to you in OPD, you identify the patient is having gastric outlet obstruction.
I will first do an imaging, sir, because we need to, for doing an endoscopy, we might have to insert an RT, we'll have to give a stomach wash. It will take some time. In that time span, we can first stabilize the patient, give IV fluids, then after that we can do a CT. Then after a CT, we can plan for an endoscopy. So, see CT abdominal and pelvis and then plan for an endoscopy.
Fine, either way is okay. Yeah. So what do you expect to see here? What is your working diagnosis as of now? You have a malignant gastric outlet obstruction.
Malignant gastric obstruction.
Possibly of?
Probably due to a CS stomach due to an antropyloric growth, sir, because it is a non-bilious movement. So antropyloric growth causing a GOO, sir.
Okay.
So if you do an endoscopy, you might see a growth there, or you might see an extensive obstruction.
Compression.
So that will clarify your diagnosis.
Diagnosis, yes, sir.
Suppose because you are saying CS stomach, so let us assume that there is a growth in the antropyloric region. What will you do then?
Sir, while doing an endoscopy, if there is a growth in the antropyloric region, I will first see the extent of the growth. Where is the growth? Then I will take a biopsy from the growth. Then I will check for stomach distensibility and whether the scope is negotiable or the scope, we cannot negotiate the scope. We will check that. And I will first establish a feeding axis. And then I'll see the CT also, sir. Based on the CT, we'll establish a...
Let us stick to upper GI endoscopy. So you are doing an endoscopy. You see a growth in the antropyloric region. The pylorus is likely to be non-negotiable. Okay, you take a biopsy. So how many biopsies you will take? You see, very common question, but very relevant, especially in today's time. Why?
Sir, I will take 6 to 8 biopsies, sir.
Why you want to take so many biopsies?
Sir, it is proven that if you take a single biopsy, it is only 70% sensitivity. 6 to 8, 98%.
Yield is likely to be more. Yield is likely to be
good, sir.
Yes. What else, especially in 2026? The pathologist always asks more tissue. Why?
Sir, we can run IHCs in that, sir. In that,
so you need to run many biomarkers in that. Yes, exactly.
So which
never ever
biomarkers?
Compromise.
So, sorry, yeah. Which biomarkers are universal as on today, and which are, say, optional?
Sir, universal as in we will ask for IHC cytokeratin.
No.
To confirm that.
No, I'm talking about the biomarkers. Okay, I'm not talking about for diagnosis. Okay, which biomarkers will you run for every CS stomach, and which biomarkers will you run for advanced cancers, advanced gastric cancers? What are the biomarkers that you want to do on this? Not talking.
IHC MMR I will run, sir.
IHC MMR, okay.
Next. Then HER2. Then PDL1 and Claudin.
PDL1, Claudin. Okay. So will you do all these 4 in every possible case?
No, sir.
There is a. No. So what will you definitely do? Consider that this is an operable, not very advanced, non-metastatic cancer. Will you still run 4, Or will you run only 1 or 2 which have to be done as on today? Or simple, what will you do for universally for everybody as per the guideline, and what will you do for advanced cases?
Sir, I will run an IHC MMR, sir.
Very good.
IHC MMR. Rest of the markers I will run if it is
One
a
more you will have to do it. One more is? Yeah, Dr. Ashish, you are back. So what are the other biomarkers that you want to?
PDL1 I would like to do, sir.
PDL1 for every case. Okay, what about the advanced ones?
HER2 and Claudin 18 too, sir.
Okay. There is one more marker which is coming up. One viral marker which is being done.
EBV, sir.
EBV. Okay, good.
So, Shada, what is the molecular classification of gastric cancer? As Hemant sir, told you about to run the biomarkers.
Sir?
Molecular classification of gastric cancer.
Yes, sir. There is a TCGA molecular classification for gastric cancer. We have 4, sir. EBV positive, chromosome instable, genomic instability, and
P53 genomic stable.
Chromosomal unstable, genomic stable, and
so Dr. Ashish, there are 2 parts of these, biomarkers. One you want to do for the classification, the molecular subtyping for the prognosis. Other you want to do for therapeutic purpose. So for therapeutic purpose, which one you would like to do? You both of you said MMR and PDL1 in all patients or only in metastatic?
Sir,
MMR and is universal, sir.
MMR is universal. So in every patient, irrespective of whether the patient has metastasis or not, you would like to get it done. Why?
Yes, sir.
Why?
Whether it is defective or not, depending upon that. If it is defective, sir, chemotherapy is not effective. You have to add on.
No.
In defective MMR.
No. You see, till now it is said that only in metastatic setting you should do it. But as for 2016, there was a trial which has shown the role of immunotherapy even in locally advanced non-metastatic tumors. That is why MMR and PDL1 should be done in a non-metastatic locally advanced, because you can add on immunotherapy to the perioperative chemotherapy. That is the reason. Okay.
Yes.
So, do we have, Dr. Meera, biopsy report of this patient?
Yeah. It's a poorly differentiated adenocarcinoma, no signature cells.
Okay.
What about the
What else
endoscopy?
will you get?
We'll just go back. Endoscopy.
Yeah. Distal growth, stasis is there. There are no varices of portal hypertensive gastropathy, duodenum not entered.
Okay. So all what we expected, entopyloric growth, pylorus non-negotiable. Okay. So what will you do now?
CT, thorax, abdomen, and pelvis should be done, sir.
Okay.
Staging.
Yeah.
Once you confirm that it is a localized disease, it is not metastatic, then you should go ahead with upfront surgery, distal gastrectomy with.
No. Let's not go there as yet. I want to do a PET scan. What does the guideline tell me?
No, sir. PET scan is not indicated because as the biopsy report is signet-ring carcinoma, which has a deficit of GLUT1 receptors, so you should not do PET CT. PET CT is not indicated, sir.
Okay. The guideline says no PET CT. Why?
No PET CT.
What PET
because
CT? Be specific. What PET CT is not to be done?
FDG PET CT is not. FDG
Yeah,
PET CT is not.
Because it doesn't help you. Okay.
Yes, sir.
Anything
Yes,
coming up? Anything coming up?
You will not be getting PET CT in any of the scenario, Dr. Ashish?
Will do, sir. FAPI PET can be done. And secondly,
no. I'm talking about FDG PET CT only. You have been very categoric about it.
Yes. Sir, FDG PET CT is indicated when you are equivocal. If CT is equivocal or MRI CT is equivocal, in those cases you can go for PET CT, as well as response evaluation is better assessed with PET CT.
You see, in today's time, PET CT, you can get both things done. You can have a very good contrast enhanced CT. You can get PET also. So why not to get a PET CT in all patients?
Adds on to the cost. Secondly, it adds on to
Yes,
the
very good.
Sir,
So unnecessarily, it will cost to add to the cost of the investigation. And
yes.
secondly, it may
Other
it may
unnecessary false uptake or pseudo uptakes can be.
very good, excellent, very good.
Okay.
Would you
So
like to
what
see
are
the
the
seat?
Yeah, let's go ahead.
We'll quickly move on to the abdomen. Just nothing much is there.
What contrast do you want to use here?
Oral IV
Oral
contrast, both.
what? Oral
Oral
what are the different types of oral contrast you would use for CS stomach?
gastrographin,
More than that, before that, something else?
negative
oral
contrast,
no,
sir, with
negative
water.
contrast, mannitol or water.
Mannitol or water? Yeah. How does it help you?
It will distend the stomach little bit, sir, so we'll be able to see the mucosa better.
Yeah.
Not mucosa, the intraluminal part of it better.
Okay. Go back. So what do you come on? Go and describe. Prashish, can you describe the scan here?
Sir, there is a
Yeah, go on. Sure.
we can see it is a contrast enhanced CT scan of abdomen, which shows a grossly distended stomach.
So can we pause here?
With
Yeah.
With hyper intense heterogeneously enhancing lesion at the antrum and pyloric region, sir.
Can you scroll down and point out?
Sir,
Okay. Yeah, please go
I'm
ahead. No
opening
problem.
in my phone. So,
No problem. That's okay. Fine. Okay. What
sir,
else do you
this
see?
is an extension.
Yeah. What else do you see? Can we go down a little more towards the duodenum? Okay. What else are you looking at? When we go up, I'll focus something here.
Sir, there are multiple perigastric nodes.
Okay. And what else do you see? Quickly.
Liver is normal. There is no ascites.
Liver is normal.
No ascites, no,
No ascites.
Can we focus
growth
on
is
that? Do you think
local.
we need to focus a little on the liver in this case? A little more than what we need to in other cases? What are we worried about liver here? Not only
Cirrhosis. Changes of cirrhosis, sir.
even if there is no cirrhosis, yeah, if you can,
There is no
any
cirrhosis
chronic liver
as such,
disease
sir.
picture. Okay, fine. Liver looks good.
Yes,
Okay,
sir.
the right lobe looks good.
Gallbladder is distended with perigastric nodes and growth in the distal
The caudate
stomach.
is also okay. It doesn't look like the caudate is too big in proportion
Yes,
to
sir.
the liver. So it means that the liver is reasonably good. Okay.
Yes.
So what
sir.
else do you want to see other than the stomach, liver, peritoneum, and all? One important thing
Pancreas,
which all,
sir. Pancreas, is it direct infiltration to adjacent structure has to be looked.
what does it
Like
look like
most,
here?
doesn't seem, sir. Well-maintained fat planes
Looks
with
like
the
a very nice
pancreas.
fat plane here. Okay.
Yes, sir.
And
Yes,
one
sir.
more important point, especially one more important point, other than the disease characteristics, what do you want to focus on?
Sir, arterial anatomy we will check.
Okay.
Planning for surgery.
Right.
Um,
So what does it look like here? Looks operable? Looks not operable?
Operable, sir.
Sir, it is operable, but there are multiple perigastric nodes. Bulky perigastric nodes are there.
So how will you classify this disease?
Locally advanced gastric cancer.
Locally advanced gastric cancer, adenocarcinoma,
Adenocarcinoma
poorly
with
differentiated with gastric outlet
obstruction, sir.
obstruction. Okay, so now what will you do? Anything else you want to have? Or any other investigation?
CT thorax has to be done, sir. If it is
that is
not
already done.
Sorry, sir.
No evidence of metastasis in the lung.
So it is, as it is a locally advanced gastric cancer with a gastric outlet obstruction. So upfront surgery, we can go with a distal gastrectomy
what
with
will
a
you
T2
do? Dr. Ashish, what will you do?
I will do
Sir, I will.
distal. I'll plan for surgery, sir. First, I will stabilize the patient by giving IV
So
fluids,
you will optimize the
decompress,
patient. Very good.
optimize the patient. Yes, sir. I will
Mhm.
optimize the patient. I will look for the blood parameters,
Mhm.
so that look for hemoglobin, whether it is normal or albumin. I will look.
I think that we
LFTs,
discussed
bilirubin.
already. Can you move to the management?
Okay, ma'am.
So there is
I'll like.
So
Once I will.
pre-operative habilitation or the optimization, and then what will you do?
Sir, I will do
Then
a staging laparoscopy,
staging
sir.
laparoscopy. Sorry, sir. Staging
You will
laparoscopy.
do a staging laparoscopy. So what will you do in
No,
a staging
not in
laparoscopy?
Sir,
not
sir,
in
I can't.
not in gastric outlet obstruction, sir.
Dr. Ashish and Dr. Sada, I think both of you do not speak simultaneously. So first, I think Dr. Ashish.
Sir, gastric outlet obstruction, there is matlab, staging laparoscopy has no role, sir. We
So
have we can
you will do a laparotomy straight.
yes, sir.
So you will do a laparotomy, and then what will you do? So in laparotomy, suppose there are multiple peritoneal nodules. So what will you then?
I'll do I'll do
I think, Dr. Meera, thank you.
I will do distal
No. You see, you
gastrectomy.
have multiple scenarios now. You
No, no,
opened up the patient.
See, Dr.
There
Ashish,
is a
what is preventing you from doing a diagnostic laparoscopy here? Do you think the diagnostic laparoscopy or staging laparoscopy has no role here because the patient has a GOO? What is your thought process? You say you want to open, so why do you want to, directly go ahead and open? What is your thought process here? I will say
Sir,
that whatever
saying,
you are planning to do, possibly I can do it without opening up also, or the patient may not require an opening up here. What is the purpose of a staging or a diagnostic laparoscopy in this case? What is the aim of
to
or
detect the detect the peritoneal mets.
okay,
M1
so
has it metastatic.
basically to avoid an
Unknown.
unnecessary laparoscopy. Okay, I understand the patient has GOO, but still I feel that laparoscopy has a place. Why? Sir has already given you one clue. One, there,
To stage the disease, like to look for peritoneal deposits.
correct. Supposing there are peritoneal deposits, okay, can you
Yes,
not
sir.
still, then what would you plan to do?
And I would like to take biopsy, and if it is positive, then I would like to give neoadjuvant chemotherapy followed
But you
by.
can't give neoadjuvant here. The patient is totally obstructed. Is there anything that you can do laparoscopically? Provided, you or
Laparoscopy.
your senior
GJ,
or your teammate,
GJs are bypass,
okay, bypass,
palliative surgery.
okay, palliative surgery. So don't rule out a laparoscopy, right? So what are the
Yes, sir.
different types? Supposing we are thinking there are multiple scenarios here. Let us go with scenario one where there is extensive disease. Patient has got a lot of peritoneal disease, probably some ascites, okay, and is going a total obstruction. So what will you do? You will plan a bypass, right? You
Yes, sir.
want to do a
Yes,
GJ. So what
yes, sir.
kind of okay, you prefer doing an open GJ? Fine. After doing this, you'll go ahead and you open and then do a GJ. What are the other ways to do a GJ?
Sir, we can do.
Especially relevant in this particular day. On this particular day, there are different ways of doing a gastrojejunostomy.
Sir, we can do a
Two
endoscopic
and twice
GJ.
endoscopy.
Let's go
GJ.
stepwise. Let's go. We are surgeons first, right? So you'll do an open GJ. You will do
GJ. Lab
a lab GJ,
GJ.
or you have an option of a
Endoscopic.
endoscopic GJ. Okay. So there's a very interesting article which I read, which is comparing all the types of GJ. What do you think is the most cost effective of everything, of all of this? There is one more GJ, another GJ, another type of GJ, which I have no experience. Dr. Garg should tell if yes. There is one more type, another type of GJ.
Sorry, sir.
Stomach partitioning gastrojejunostomy. Do you know what that is?
No, sir.
Okay, so what you do is you basically fire a stapler. You do a GJ, you fire a stapler between the growth with a sufficient margin, right? And then you don't completely divide the stomach. You fire a 5 centimeter on the greater curvature, leave a little part of the stomach connected to it. So basically, you are separating the distal part of the growth from your GJ side, so that your GJ works much more effectively, right? So out of these four, what do you think is the most? I was surprised myself. What is most cost effective of all of them to the patient? No, it is surprisingly in a cost analysis. It is no, not even lab. It is an endoscopic EUS guided. If you can do it, if your center has that maturity, it is the most cost effective. The best in terms of functional outcomes is probably an open GJ or the partitioning one, which takes a little. It's a bigger procedure, as the patient needs to be more fit. But surprisingly, the cost effectiveness of an endoscopic procedure is higher. So you are not opening the patient up also. So that is so don't rule out laparoscopy, right? So this is where you have extensive peritoneal disease. Supposing there is very limited peritoneal, how will you assess peritoneal disease?
PSC,
we'll do
PCI index.
One of you.
PCI
Okay.
index.
Yeah.
We'll divide the abdomen into 13 quadrants and we'll assess the PCS, peritoneal carcinomatosis index, scored
Okay.
between 0 to 39.
Just a minute. You said 13 quadrants. Are the quadrants 13 or is something else 13? How many quadrants?
Regions, sir. Sorry.
So how many quadrants?
4 quadrants.
Huh? So tell me the numbers. You said 13.
Sir, 1 to 13.
No, it doesn't start from 1.
0, sir. It
Right.
starts with umbilicus.
Correct. 0 to 0, 1 to 12.
1, 2, 3, 12. It is
Okay.
12.
So how is the pattern?
Sir, it starts at the umbilicus, sir, and
Okay.
it from right upper abdomen, then epigastrium, then left upper abdomen, then left
Yeah.
flank.
So basically, you go clockwise here, right?
Clockwise. Yes, sir. Yes,
Okay.
sir.
So that makes it
And
0.
distal, 0 to 9 will be all other regions, sir, of abdomen, followed by 10, 11, 12, 9, 10, 11, 12 are divided based on the upper jejunum and lower jejunum, proximal, distal, proximal ileum and distal ileum.
Okay, fine. So yeah. And
Dr. Ashish, suppose you put a scope and there is no identifiable disease in the peritoneum or in the omentum or onto the liver. What will you do then?
Cytology I would like to take, sir.
So how will you take cytology?
Sir,
because the time is running out, so we will little,
Sir, 500 ml of normal saline is put into 5 different regions, like both the subdiaphragmatic space, both the paracolic gutters in the pelvis.
You must have listen, Dr. Ashish. You must have done many of these cases. So what you do, you tell us practically.
Practically, sir. Yeah. Practically, we usually install 200 ml of saline in intraperitoneally, sir. We'll wait and we'll suck through the pelvis.
Aspirate all that. Then what you do?
Aspirate in the right and left subdiaphragmatic.
Done. You aspirate. Then what you do?
Send it in a separate container, sir.
Send it to separate container. Then what happens?
What's it?
So your pathologist gives you report?
Yes, sir.
And how much time?
Frozen in...
No, not frozen. We are talking about cytology. You said, no? So in your center, you do a diagnostic laparoscopy. There is nothing. You put a fluid. You suck it, send it to lab. In how much time do you get the cytology report?
No, in our institute, not much routinely done, sir.
This is what I was asking you. So what do you do in your practice?
We send... We send for, if it is operable, we'll take the sample, sir, without any peritoneal deposits. If we are doing cytology, we'll set that aspirate with the main specimen. If it is operable, we do.
So you are not sending. So intraoperative decisions are not being influenced by the cytology report because you don't get a cytology report so quickly.
So there is a difference between a staging one and a diagnostic one. It's as simple as that. Okay, a staging is different from diagnostic. Okay.
Yes.
So your
Right.
these things are not changed intraoperatively. Okay. So you send it, then what will you do?
We'll go ahead with, if it is operable, sir, we'll go with upfront surgery. If it is inoperable, locally advanced, then palliative
This is an operable lesion, then what will you do?
distal gastrectomy with D2 lymph node dissections.
So what is distal gastrectomy?
Distal gastrectomy, removal of distal body, antrum and pylorus with a proximal 5 centimeter margin, with a distal 1 centimeter margin, with removal of D1 and D2 stations, like D1 1
So
to
you do the
7.
gastrectomy. Do you send it for frozen?
No, sir.
For margin assessment?
For margin assessment, if it is in the proximal stomach, sir, to assess the esophageal margin.
No, we are talking about this patient only. No?
In this case, we don't send, sir. We don't send. If it is grossly negative, 5 centimeter margin as histology signet ring. So I would not like to do any frozen section in this case.
So you will not send it for frozen section. Dr. Sharda?
Sir, so I will do a D-lab, sir, and we usually send it for cytology, and in intraoperatively, if there is no peritoneal disease, and if we take it as non-metastatic disease, I'll insert a chemo port, sir. In our setup, we insert a chemo port, and because for perioperative chemotherapy, sir, usually for locally advanced.
So you will not. Just wait. So you said there is no peritoneal disease, yes, but you will not do surgery in this patient.
Sir, preoperatively we insert an NJ for the patient. So in our setup, we do a NJ. We do a NJ, and for locally advanced CS stomach, sir, we don't do a TJ or FJ for the patient. We directly do a NJ insertion, and we do a diagnostic laparoscopy. If there is no metastasis, we will insert a chemo port, and then we'll come out, sir. Cytology, we don't send for
how many times are you able to put an NJ in a non-negotiable pylorus?
Mostly we'll insert, sir. I'm not
this particular. What is your goal in putting an NJ? Do you think it really applies in this particular patient who's got a chronically dilated stomach with a significant amount of stasis, is passing very old matter, which is 1 day old, is frail, 67, and the duodenum is not passable, the scope is not passable into the duodenum? In this particular case, I don't think your NJ will help, right? You're putting your NJ if you want to give the patient that kind of fitness for him to take a perioperative chemotherapy at 67, right? If you are especially looking at FLOT, I don't think that is a scenario here in this particular case. In this is a particular case where the patient requires some sort of either a curative surgery, like or some palliative procedure, right? So I don't think we should be talking about building up the patient here, because you might build up the patient here for this particular surgery, not for.
I think Dr. Sharda and Dr. Ashish, this is classically what the controversy in the management of CA stomach is: East versus West. Ashish belongs to the East party, and Dr. Sharda belongs to the West party. Dr. Sharda wants to give a perioperative. Ashish is more like a Japanese and Korean and wants to do surgery.
No, Dr. Pankaj, I think the scenario here is that they don't see enough of these obstructions nowadays. Right? We are very.
I agree, Dr. Hemant, but this is exactly what I am saying. So these are the institutional preferences which might be different. So you put a NJ tube, you put a chemo port, and wants to give a perioperative chemo. Yes. Okay, and Dr. Ashish wants to do a D2 lymphadenectomy, a D2 gastrectomy, a distal gastrectomy. Dr. Sharda, do you do a frozen section if you are doing a distal gastrectomy?
Sir, we will cut open the specimen and we will see the specimen. And if we feel that there is adequate margin,
it is coming close to the distal margin. Unfortunately, what will you do then?
Then we will send for FS, sir.
FS sent, pathologist says, unfortunately, the distal margin is positive. Then what will you do?
We don't do resection, sir. We don't do.
Then why did you trouble your pathologist?
We don't usually.
How much down can you go? See, this is a worry. As in these scenarios in GOO, my worry is, will I get a duodenal margin? I'm not worried much about the proximal margin, okay, because if I've ruled out rhinitis and all things like that. Second thing is the peritoneal disease. These are two pertinent cases in this particular thing. So duodenum, how much down can you go? How do you
D1.
assess?
Till
How
D1,
much?
we will cut a stapler, sir.
You will cut and staple, or you will staple and cut? Because once you cut, it is very difficult to staple.
Sir, we will staple and cut.
So how far can you go? How far can you push your stapler?
Till D1, we will cut, sir. D2.
What are you worried about in D2? And how do you?
Sir?
Why don't you want to put your stapler in D2?
Sir, D2, there is ampulla.
Correct. So how will you?
So
Ampulla, you don't
Is
see
there
from
any
outside.
landmark? Is there any landmark? Outside, is there any landmark?
Ma'am, we will not disturb the GDA, ma'am. Should
So
not go
you,
to that.
yeah, so you will not go beyond the GDA. You will
GDA,
stay to the
yes.
right of the GDA. Fine. Now, supposing we quickly go through these scenarios where there is, you find limited.
Hemant
peritoneal
sir,
disease.
just I wanted to ask Ashish, because he belongs to the eastern side, that your distal margin is positive. Would you like to do a pancreaticotonectomy in this patient? In case the distal mother, Dr. Sharda said that she will not revise. Dr. Ashish?
Sir, on table assessment you are asking, sir, if you are
Yes, distal margin is positive, you send it for frozen, distal margin is positive. Would you like to do a pancreaticotonectomy?
yes, sir, we have to do if we found that there is positive margin, but it is gives much more morbidity to the patient, the outcome, and for this
So
patient it is
more or less you can do, but whether you
Yes,
will
sir.
be doing it is a big question, because the literature suggests that this procedure does not help the patient in survival. So in a very strongly, very selective patients, you might think of doing it. So it is not
Yes.
a question of whether we can do it, but the question is whether it will help the patient. Hemant
Yes.
sir, your opinion on this?
Yeah, at 67, I don't think I'll attempt to do it.
Okay, Dr. Ashish. So I think Dr. Hemant sir, quickly these scenarios.
What, sir?
Quickly we can go through these scenarios as you said.
Yeah. If there is intraperitoneal disease limited to omentum, what would you do? Will you operate or?
No, ma'am, will not operate.
Dr. Sharda is actually
Adjacent
clear about,
omentum is involved.
because no, Dr.
She
Meera,
doesn't want.
actually she is very clear because she doesn't
NACT.
want to operate even when the peritoneum is clean. So there is no question that she would attempt in these scenarios. Am I correct, Dr. Sharda?
Sir,
Is there any?
Is there any
Dr.
simple
Sharda,
question? Simple question. Is there any benefit to a palliative gastrectomy, palliative resection?
Correct.
Sir, we can do a palliative GJ, sir, for the patient.
No palliative gastrectomy? No proven benefit?
No proven.
No, the data goes either ways, actually.
No proven benefit, sir. Initially, it was done for debulking of tumor and reducing the tumor load, but the studies have shown that there is no benefit to overall survival. And
Can you name the trial which suggested that, or highlighted this?
sir, I am not.
We will talk about this. Okay.
Fine. Okay. Well, I'll give you certain scenarios. Okay. Fine. This patient you say is you find positive cytology. There is not much GO. You can give neoadjuvant chemo, and you want to come back and operate the patient with limited peritoneal disease. So, up to what PCI do you operate in CS stomach?
Less than 7. Less than 7, sir.
Less than
6
7.
or 7.
6.
Is it a standard, Dr. Ashish?
It is not standardized, sir.
Sir, as
It is
per
not standardized.
Sir, as per
Yes,
recent trial, there is no role for CRS and there is no role for CRS in a gastric CA, sir.
So outside, I think trial or outside,
Limited
there is no role of any palliative gastrectomy or what we call a tumor volume reduction surgery.
No tumor volume reduction surgery. No, even isolated metastasis resection does not. Till now, there is no study which is proving survival for.
So your patient, you have put in a chemo port now, and you have put in an NJ tube also, and then you will be sending the patient to your medical oncologist friend. So what chemotherapy do you give?
Sir, based upon the patient's fitness, sir. If the patient is fit for FLOT, then we will proceed with FLOT chemotherapy. And we'll take a cardiology fitness, we will take the medical oncologist fitness, and we'll send for FLOT chemotherapy.
What is the main problem with FLOT?
Sir, patient will need 5-fluorouracil infusional chemotherapy. It is an infusional chemotherapy. So cardiac fitness is essential.
The two things, hematological and cardiological.
Sir, it can also develop hematological like neutropenia, neuropathy, and diarrhea are more
Your patient was very fortunate, tolerated all four, FLOT therapy. What will you do then?
I will reassess the patient, sir.
How will you reassess the patient?
Clinically, I will reassess the patient, whether his GOO has become better, whether it has resolved. Then I will check.
Unfortunately, though the patient, tolerated the therapy well, but the disease is still same, your CT says. What will you do then?
Still the same as in CT also.
There is no reduction. It is same. 4 cycles, disease is same. It's still non-metastatic, resectable, as it was prior to FLOT.
Will you resect it now?
Ma'am, I will do a
We will resect. We will resect,
You did a
sir.
diagnostic lab again. There is no peritoneal disease. Then what will you do?
If it is resectable, I will proceed with surgery, sir.
So this time you will do surgery or you will switch over to second line chemo?
Same chemo.
I will proceed with surgery, sir.
Now you will proceed with surgery and Ashish wants to go for second line chemo.
Sir. No,
you
sir.
Had already
sir.
operated, you had already operated the patient.
No, I will operate, sir. Even it is
You
non-responder.
had already operated the patient. You were in the upfront surgery group, bhai. So Dr. Sharda will be operating. You do not want to change chemotherapy this time? So FLOT is the best therapy that you can offer. So you have not much more options available.
Anything else is being added to FLOT these days? The recent guidelines which just come in, other than FLOT?
We just discussed that.
Durvalumab plus FLOT we can add.
Okay. We'll quickly name of the trial which has put it in.
Sir, for OG junction, proximal
No,
tumor.
No. Specific. Hemant sir is asking. ASCO 2026 results are out.
Okay.
We had an editorial in that IJSO. You should read IJSO more often.
Okay.
Yeah. Should we move on to
I will tell you in my talk.
Yeah, we'll move on to the next case. Sir is going to answer the question in the talk. Because we are running out of time.
Second case, a 65-year-old gentleman.
I think we'll directly go to the diagnosis and
yes.
Okay. Dyspeptic symptoms, upper abdominal pain. It's a locally advanced carcinoma stomach. No findings per se on examination. History of dyspepsia and upper abdominal pain. So how would you like to proceed?
So no gastric outlet this time?
No.
Yeah, the imaging please. Imaging and the endoscopy.
No, imaging. We want to know
imaging
the
and the endoscopy.
And the endoscopy.
Do we have it with us, Dr. Srijan? Looks like Dr. Meera.
Yeah. One second. Yeah, so this is the imaging.
Madam, please read out the report because we are running out of time.
Yeah, it's a wall thickening proximal stomach with effaced fat planes with the left lobe of liver. Small perigastric nodes.
Okay, and endoscopy?
Endoscopy, also ulcerated growth with diffusely infiltrative margins, proximal stomach, starting 1 centimeter from OG junction, almost up to incisura. Biopsy
So how will you TNM stage this patient, doctor?
involving the
Yeah, so I'll summarize. It's a proximal gastric cancer starting about 1 centimeter from the OG junction.
okay.
Okay, and imaging wise, there is some effacement of planes with the liver, and there are perigastric nodes. Right, madam?
Yes.
Yeah.
Perigastric nodes are significant, Dr. Meera?
Small nodes.
Should we
Small,
label it as
small.
N0 or N1 or N2?
N1.
N1, okay.
Uh,
So your TNM stage, Dr. Sharda, would be of this patient?
Sir, there is liver margin is little effaced fat planes with liver. The
Yeah.
CT finding.
Yeah.
It could be T4 serosal disease might be there, sir. So T4A or T4B might be based
So
upon the two.
T4A, N1, N0, correct?
Yes, yes, sir.
Okay. What will you do now? And then this adenocarcinoma, biopsy proven, not metastatic. What will you
Patient
do
is
now?
not in GO.
Patient is not in GO.
Not in any obstruction.
It's an
So not
inlet
in
issue this
obstruction.
time, not the outlet.
Sir. Sir, well, we'll do a biopsy. I'll again do
Biopsy
biopsy.
adenocarcinoma.
Okay. NACT. We'll send the patient.
So you again want to go for the plot. Dr. Ashish, any difference of opinion?
DLAP I will like to do, sir.
DLAP and
So
NACT.
you, Dr. Sharda, you wanted to do a DLAP or instead you wanted to send the patient to medical
No,
oncologist?
I want to do a staging laparoscopy, sir. After staging
So first you want to do a staging laparoscopy.
laparoscopy. If there is no peritoneal disease, then I will go ahead with the chemoport insertion and send the patient for.
So do you send cytology at this stage?
Cytology. We'll send for cytology. Yes, we'll send for
Yes.
cytology and.
Dr. Ashish,
Yes, sir.
any difference
Yes,
of
sir.
opinion or you want to do the same?
DLAP and send for cytology, sir, to further stage the disease.
Then
Then
T4A, N1, M0 is potentially resectable lesion. You don't want to do surgery?
no, sir. I would like
It is
to.
only N1, non-bulky node. That is why I specifically asked Dr. Meera.
No, sir. I would like to give neoadjuvant.
So
Why?
you would like to give neoadjuvant. So again, I would say there is a difference of opinion between the eastern side of the globe and the western side. Eastern side, even in T4, they wanted to know about whether they are bulky nodes or not. So perhaps the only criteria for giving chemotherapy is bulky nodes.
Yes.
But if you look at the western side, everybody would be giving anything more than T1, M0, M0. So any lesion which is T2 above or any node positivity is an indication for perioperative chemotherapy.
Perioperative chemotherapy.
In Eastern,
Okay.
sir, if you are
So
able to
you
get.
left your friends in Japan. Okay. So
Sir,
again,
sir, if
so you would
we
be.
can
Mhm.
if
Say
we
it.
can get
Go ahead.
R0 resection,
You
even
would
with
be getting an R0 dissection. You assess, you put a scope, and you assess that R0 dissection is possible. Would you like to do a surgery?
yes, sir.
You
Is
are
there any-
now changing sides.
Is there any evidence to say that primary surgery versus NACT, which is beneficial?
Yes, Dr. Ashish.
This is a
Ashish.
proximal gastric cancer. There is significant
Yeah.
amount of evidence, right? A lot of these studies, the perioperative studies have been done
Perioperative chemotherapy.
on which segment?
In those trials, the other arm did not have adjuvant chemo, so
Yeah, I know.
that's
So there probably is some benefit here.
some benefit. Yeah.
There are perioperative chemotherapy trials are there, sir, which will tell. There is magic trial, there is flawed trial.
Suppose
then there
you
is
want to
the
go ahead and
flawed
do a
AOC.
surgery here.
Doctor.
Yeah, please go on. Yeah.
No, this is exactly what because you see the magic trial and then the flawed trial. So this is what exactly I am saying. So there was so much benefit in those trials that all of us want to give perioperative chemotherapy in all patients of CA stomach. Any lesion which is T2 above, T2 or T2 above, just T1 we want to give.
Operate.
We want to operate upfront.
Yes.
In contrast to that, if you see the literature coming from the Japan, the things are different. Okay. So there is a definite east to west divide between these two. So for them, the criteria is not only the T lesion, it is basically a bulky nodal disease. So if there is a bulky nodal disease, they want to give chemotherapy. Okay.
Okay, sir.
Yes, sir.
So you have given this time 4 cycles of chemotherapy, plot, you get a CT done, there is a good response. What will you do now?
Surgery.
Sir, I don't understand. We'll do
What
surgery.
surgery you will do? What surgery you will do in this patient?
Sir, the distal extent of the growth, ma'am. There is a distal extent.
Up to incisura.
1 centimeter from OG junction.
Up to incisura.
Up to incisura. Okay. We'll proceed with the total gastrectomy. Total gastrectomy and D2 node dissection.
You will be removing all nodes. What nodes you will remove?
Sir, there will be D1. D1 includes 1 to 7 nodes we will remove, and 8A, then 9, then 11T and 11D and 12A nodes we will remove.
Why not 10?
So level 10 nodes usually we don't remove, only in when there is
No, but why you don't remove them?
Sir, it does not provide any survival benefits, sir. Removal of level 10 nodes does not provide any
It's a regional
survival
node, you don't want to remove it, any specific reason?
Splenic,
It's a regional node.
Spleen, there will be, it is close to the splenic hilum, sir. There is a chance of
Yes.
injury to the splenic vessel, and we might
So
end up
first
doing a
thing is
splenectomy also.
splenectomy. So any indication where you want to remove this 10, station 10?
Sir, for proximal gastric lesion involving the greater curvature of stomach, if we will remove the level 10 nodes.
So that will be the scenario where you might contemplate removing the station
10 nodes.
Station 10.
Station
Okay.
10 nodes.
What about, would you be doing a cholecystectomy for this patient? Do you do cholecystectomy when you do a gastrectomy? Total gastrectomy?
No, sir.
What about you, Dr. Ashish?
No, sir. No, sir. We don't do, sir, cholecystectomy.
Should you do it or should you not do it? And all those who do it, why they do it?
With total gastrectomy, there will be injury to the vagus nerve. There will be stasis, calcular formation, and all other complications can
Yes, so
redo
there is a
surgery.
group of patients, there is a group of surgeons who believe in this because of the truncal vagotomy. There could be stasis and can lead to stone formation. So they do what we call it an incidental cholecystectomy in these group of patients with total gastrectomy. Okay.
Yes, sir.
Does the new guideline, let's see how much the new things you have read. Does the new guideline say anything about vagal preservation?
Sorry,
The seventh Japanese Society for Gastric Cancer. Does it talk anything about vagal preservation? Which branch of the anterior vagus and which branch of the
highly selective truncal vagotomy?
No. Which branch of the anterior vagus do you preserve and which branch of the posterior vagus do you preserve?
Nerve of Litarch.
No, I won't answer this. You go back and read the 7th edition of the Japanese Cancer Society guidelines. Okay. Now,
Dr.
supposing
Sharda,
it is.
Yes, please go ahead, Dr.
Yeah, one last question.
Yes.
So
yes,
supposing the growth is starting from 1 centimeter and ending at about the lesser curve partially involved, ending about 2 to 3 centimeters down. So what will you do? Do you want to do a proximal gastrectomy or a total gastrectomy?
Sir, I can't hear you, sir.
Proximal gastrectomy or a total gastrectomy if the disease is about, say, 5 to 6 centimeters in length. Lesser curve is partially involved and partially free.
Sir, we can proceed with the proximal gastrectomy also, sir. Proximal gastrectomy we can.
What is a standard gastrectomy according to the Japanese classification? Dr. Nair, Dr. Ashish, because you were talking about the
total gastrectomy or the distal gastrectomy are the standard.
How much of the stomach do you have to remove?
No.
As per the guideline.
Listen to the question of Hemant, sir. Listen to the question carefully, then you answer. What is standard gastrectomy?
Standard gastrectomy definition. How much of stomach is removed? How much is preserved? Is proximal simple questions. Is proximal gastrectomy classified under standard gastrectomy?
Yes, sir.
Huh?
No, sir. Total gastrectomy and distal gastrectomy are classified in
Why? How much of stomach do you have to typically remove as per the Japanese
two-third of the stomach.
two-third? And what about in proximal gastrectomy? How much do you remove? How much do you leave? By definition.
Distal 1/3 has to be left behind with antrum and pyloric preservation.
Okay, it is half actually. Okay, fine. Yeah, anything more? Because I think it's time for the talk. Any more specific questions, issues that you wanted to discuss, Dr. Meera? We'll just take 5 minutes. And
Peritoneal fluid cytology during diagnostic lab comes positive. You took a peritoneal fluid cytology during the first diagnostic lab. It is positive. What do you do?
Ma'am, if it is positive, we can give 4 cycles NACT and we will send the patient again a DLAP and we'll again send the repeat cytology. If the repeat cytology is negative, we can attempt to do a gastrectomy by the guidelines. Conversion surgery is given, ma'am. It is not, there is no RCT still to tell that conversion gastrectomy is gives any survival benefit, but there has been retrospective analysis. It has shown that there is some benefit in doing the conversion gastrectomy.
If it's still positive, do you consider HIPEC?
No HIPEC. We don't consider. If it is still positive, the patient is for palliative.
Or you can put it this way, that this is not the standard recommendation, but
It's not the
yes,
standard
there are
recommendation.
select centers which are doing it in a select group of patients after perhaps an MBT discussion.
Yes.
I think that's it. We can move on to. I think that is it.
Yes, thank you very much. We will now move on to the expert talk. Dr. Pankaj, can I ask you to please share your screen? We'll visit the Q&A section after your talk. I request both the examinees to now mute yourselves. Thank you.
Is it visible to all?
Yes, sir.
Thank you so much. And I'm really thankful to the IASO leadership for giving me this opportunity to discuss, today's seminar, the contemporary management of gastric cancer. Since I have only 25 minutes, I would try to, go through the things in a very brief but very clear way, so as to give a clear message to all the trainees. So you see, if we look at the Globocan 2024 data, the stomach as a whole worldwide is the 5th most common cancer. And if we look at the males, it is the 4th most common, and in females, it is the 7th most common cancer. And if we look at India, the stomach is the 6th most common cancer, combined both sexes. While in males, it is the 4th most common, and in the females, it is the 9th most common. But the good news is the incidence of stomach cancer is coming down. If we look at the trend over the years or perhaps over the decades, the incidence of gastric cancer is coming down. Since we do not have this specific data for India, I could not, show you. But globally, if you say, the message is very clear, and this is the good news. The reason that has been attributed to is perhaps, widespread use of anti-helicobacter therapy that is being given to the patients with dyspepsia, which has caused this decline. You can call it, this was an, unintended benefit that we could get. Now, what has changed in the gastric cancer management in the last 4th decade? Initially, if you look at the data, prior to 2000 in 1990s, we were discussing and, debating about the lymphadenectomy, that what should be the extent of lymphadenectomy. And there were very famous, you see the MRC, trial in the Dutch trial, where we debated that what amount of lymphadenectomy we should do. This should be a D1 or a D1 plus or a D2 or a D3 lymphadenectomy. Gradually, we came to the conclusion, especially with the 15-year data of the Dutch trial, that D2 lymphadenectomy should be the standard of care. So once we, concluded this, the quality surgery for the gastric cancer, we started talking about the systemic therapy. There was a discussion about the perioperative chemotherapy, the MAGIC trial came in. But finally, with the FLOT trial, as we just discussed also, everybody, especially the western side of the globe, was convinced that FLOT or the perioperative chemotherapy is the way forward to improve the survival. And we were giving perioperative chemotherapy in almost all patients, like T2 plus and NEN node positivity. In the same time, there was a lot of progress in the surgical modality also. We had a laparoscopy, then we had a robotic. So minimally invasive things were progressing very fast in this. After 2020, there has been a lot of progress in the biomarkers, especially. And we recently discussed about this MSI, MMR, because the immunotherapy, the checkpoint inhibitors, they were not only a part of the management of the metastatic disease, but also in the, they came into the management of locally advanced cancers as a perioperative chemoimmunotherapy. So the investigations, you see, if we look in the gastric cancer, the standard we discussed is the esophagogastroduodenoscopy. We take multiple biopsies. All of us are convinced minimum 6 to 8, enough to have a good yield, as well as enough to have a good tissue for these biomarkers. The lesion is very small. We hardly ever see these small lesions, especially in India, because we do not have screening. But if you get a very small lesion, perhaps a targeted biopsy, usually 2 would be sufficient. But again, I would reiterate that we hardly see this group of early cancers. So histology, we always send this tissue for histology and the molecular biomarkers. There are molecular subtype we require. You see P53, the MSI, the ABV positivity. So this is what we will send for, especially then we will got a PDL1 MMR. Now the claudin 18.2. Why it has become so important to send it? Because now we have a targeted therapy against this also. That is the zolbetuximab, which is available and approved by the Controller General last month only. Though the therapy is very expensive and the drug has to be imported. Now, once we diagnose that this is a case of CA stomach, we need to assess the extent of the disease. And the CT, chest, abdomen, and pelvis is the primary investigation that we would like to do, which to assess the extent of the primary tumor, the regional nodes, and the other metastasis. Now, in order to detect the occult peritoneal disease, staging laparoscopy plus a peritoneal wash cytology remains the standard of care. Now, coming on to the role of endoscopic ultrasound. As I said, we hardly use it because majority of our patients are locally advanced only. In my personal, I have hardly seen any T1. Last T1 that I saw was 5 years back. So the endoscopic ultrasound helps assess in the depth of invasion to differentiate whether it's a T1A lesion or T1B lesion, which would help the endoscopist decide whether it would be fit for an EMR or ESD. We would discuss. Assessment of regional lymph nodes is not very good as compared to CT. So CT remains the standard of therapy. So if you ask me what is the role of endoscopic ultrasound in gastric cancer without, besides assessing the T1A versus T1B, there is not much of a difference. It may be an adjunct to a CECT. So the practical algorithm would therefore be upper GI endoscopy, biopsy, CECT staging, EUS, only if the depth and the local nodal status is uncertain, and it may change your decision of endoscopic treatment to surgery, where the EUS may really help us. But again, I would reiterate, in India, we hardly see those cases. Now we discussed about the PET-CT. So what is the role of FDG PET-CT? It is an adjunct, not a routine replacement for a contrast CT. It is only useful when there is a suspicious distant lymph nodes or metastasis or metastatic site which require classification, especially in a locally advanced disease where the finding an occult metastasis would change the intent of treatment from curative to palliative, where we may ask for a PET-CT, FDG PET-CT. Limitations, because this is a diffuse type or a signet ring or a mucinous type, they are not FDG avid tumors. So there is a poor sensitivity in identifying the peritoneal disease, and the limited value in early gastric cancer. So a negative PET-CT does not exclude the metastatic or the peritoneal cancer. So as on today, PET-CT is used only for as a problem solving or identifying an occult metastatic staging, not routine. Now somebody talked about the FAPI. So FAPI is a fibroblast activation protein inhibitor, PET-CT. It targets the cancer-associated fibroblast in the tumor stroma rather than the glucose metabolism. The studies have shown that it has potential advantages over PET-CT in the form of better detection of FDG low tumors, particularly in diffuse and signet ring histology, It has got a promising result for peritoneal metastasis. It may improve detection of occult metastatic disease and can help in staging. So the potential clinical niche that we can discuss is, should be done when the CT or the FDG PET CT is equivocal, high suspicion of occult peritoneal metastasis, and for some reason you do not want to do a staging laparoscopy, or a diffuse or signet ring carcinoma, which we know will have a low FDG avidity, where you would like to go for a FAPI PET CT. But it's still, I would say, is not the standard of care. Evidence is evolving. We have to wait before it becomes a standard of care. So this is, you can see and you can compare a FDG PET CT versus a gallium FAPI PET CT. Here you can identify that it has nicely delineated this, uptake onto the surface of the stomach, which was not visible on an FDG PET CT. So yes, FAPI PET CT seems useful, promising. Let us wait for further, results to come. Now, this is a slide showing, a holistic management of a patient with gastric cancer. So we start with a clinical presentation and staging, whether the patient is screen detected or symptomatic. Majority of our patients in India are symptomatic, and though they are diagnosed with gastric cancer. We do investigations to identify whether the TNM is staging or not, resectability, bleeding, whether they have symptoms in the form of bleeding, gastric outlet obstruction or perforation, or whether peritoneal or distant mets. Then we assess the tumor biology in the form of histology, molecular subtype, PDL1, PMSI, MMR, HER2, and Claudin 18.2. And then very, very importantly, I would say, especially in our setup, the patient factors are very important. Performance status, comorbidity, social and economic factors. It is easy to say. You see, we discussed about FAPI, Claudin. You see, the economic factors are very important, how much the patient can afford, and the cultural beliefs and the patient preferences. Now, with all this, whenever you are doing all this, please remember to optimize the patient and the symptom control, which is very important. We should not only, focus on these things and we forget about the symptoms of the patient. So, symptom control and optimization. Once all these details are available, we go to an MTT, discuss our patient there. Now, for a non-metastatic setting, either we can, plan for an upfront local treatment, which may be either in the form of an endoscopic treatment or upfront surgery, or it could be a neoadjuvant chemotherapy. And then if we are giving a neoadjuvant, we reassess. If the patient is fit for surgery, we do surgery. And then again, when the pathology is available, we go back to the MTT and decide about the adjuvant treatment. So this is the in general schema of the management of patients with gastric cancer. So again, the management algorithm remains biological, biopsy-proven cancer stage, and then we classify whether it's an early disease. Early disease, I mean, it's a T1, N0, M0 lesion. It's a resectable, locally advanced tumor, or it's a metastatic disease. So coming on to the early gastric cancer. So in early gastric cancer, the question remains whether we should do an upfront gastrectomy in this patient, or are there scenarios where we can avoid gastrectomy. So we need to assess 4 variables for this. The depth, whether it is only a mucosal disease or going into the submucosal. Histology, differentiated versus undifferentiated, whether there is an ulceration or not, or the size and in-block resectability. We have 2 modalities available with us. Either it's an endoscopic mucosal resection or endoscopic submucosal resection, or ESD. In endoscopic mucosal resection, you see the lesion is lifted, and then with the help of snare, it is taken out, and then it is subjected to the pathology. Now, it can obviously be done in a very small superficial lesion. In contrast to that, in ESD, we mark the lesion, we do a submucosal dissection, and then we go for an in-block resection and again subjected to the histopathology. So when the EMR would be, you will be doing an EMR. So in a differentiated tumor, CT1A, no, UL0 is no ulceration, less than 2 centimeter lesion, and en-bloc resection is feasible. But the caution is, as I told you, that EMR, the problem is of a piecemeal excision. So that we have to be careful. It is size limited. So you need to really identify your patients who are fit for EMR. But EMR is easy to perform, technically less challenging. In contrast to that, endoscopic submucosal dissection, where we mark, lift, incise it, and then dissect it. It should be done when the differentiated tumor CT1A, the size is more than 2 centimeter, or a T1A less than 3 centimeter, but the ulceration is present, or an undifferentiated tumor, even in T1A without ulceration, we go for ESD. But since ESD is more technically challenging and there could be risk of bleeding and perforation. So when you see these, ESD will not help, or a non-curative EMR or ESD. So when you are doing a piecemeal resection, the horizontal margin is positive. There is significant risk of a residual local disease. The vertical margin is positive. Either there's a lymphatic or venous invasion, or the submucosal depth is more than 500. Size, histology, or ulceration, which is beyond curative criteria. So these would be subset of patients which would be subjected to gastrectomy, and where the endoscopic therapy alone will not be sufficient. So EMR is a niche option for a very small lesion. ESD is preferred when an endoscopic cure is intended. However, we must remember, in Indian surgical series, over 90% of the patients present with T2, T3 or beyond disease, leaving only a very small subset of patients which are actually potentially eligible for this endoscopic treatment. Now coming to the surgery for the early gastric cancer, remember this is T1, N0, M0 lesion. So the gastrectomy, the extent would be decided depending upon the tumor location and adequate margins. We must remember that we have to preserve stomach as much as possible within the oncological safety. So distal gastrectomy or proximal gastrectomy, and here comes the role of pylorus preserving gastrectomy, which can be done in a selective T1, N0 lesions, mid-gastric tumors. If you ask me honestly, I have never done a pylorus preserving gastrectomy because I could never get this select group of patients. And the lymphadenectomy will depend upon the CTT and C end stage. For a selective T1A lesion or a small differentiated T1 lesion, a D1 lymphadenectomy is sufficient in this group of patients. While for any other thing, it would be a D1 plus. Remember, again, reiterate, it is an early gastric cancer we are talking of. T1, N0, M0. So we are talking of D1 and D1 plus. There is no role of D0. Here D2 is not required. So D2 is a standard of care for anything more than T1 lesion or an N plus disease. I'll discuss that D1 and D plus later. So now coming on to the locally advanced gastric cancers. Here, this is what I was talking about, the divide between the east versus and west. On the right, on the left side is the, or I should say on the right side is the east side. So they assess if there is a non-metastatic disease, T1 and N plus, they'll straight away go for D2 gastrectomy. Even in T2, T4, they'll ask whether they are bulky nodes or not. If there are no bulky nodes, they'll go for an upfront surgery. But if there are bulky nodes, then perhaps that is the only indication for considering an NAC2. Otherwise not. So there is a big divide. So they subject the patient to D2 gastrectomy, and depending upon the histopathology, final histopathology, they decide the adjuvant treatment for this group of patients. Now coming on to the western side of the globe, as I discussed earlier, anything T2 or more than T2 or N plus disease, all patients go for gastrectomy. Now T2 N0 again is a controversial. There are papers which have suggested to go for a NCT even in this subset of patients T2 N0. But perhaps majority of the patients, majority of the centers would like to do a upfront surgery in T2 N0. So I reiterate, any lesion more than T2 or N plus disease will go for NACT. So this FLOT4 actually changed everything. The trial was published in 2019, and after that, we were all talking about perioperative chemotherapy because the benefit was immense. 50 months in FLOT versus 35 months in ECF and ECX with the HR of 0.77. After that, so not only the longer PFS, higher R0 resection rates and higher PET-CR. So perioperative FLOT has become the standard of care for resectable, locally advanced gastric or G-junction tumors in the West. I told you the East, the things are little different, but not much, because the Asian evidence is also evolving. If you talk about the RESOLVE trial from the China, the Prodigy trial from the South Korea, these two trials are also showing a direction towards a perioperative chemotherapy in locally advanced gastric cancer. Now, this was the trial I was talking about, JCOG 0501, which has shown that even in advance, perhaps there was not much benefit of perioperative chemotherapy or no survival benefit with a perioperative chemotherapy in advance. And this was the reason that many of the centers in Japan still continue to do an upfront surgery. But scenario is definitely changing. Now, coming into the Matterhorn trial that we just discussed, presented this year in ASCO 2026, where we have added durvalumab to a perioperative chemotherapy. The result seems encouraging. You see the EFRs, the event-free survival rate, the HR is 0.7, and the grade 3 to 4 adverse events were overall similar. So now it has been added as a part of clot therapy. The finances remains a big question. Now, what you should do in a patient, a distal gastrectomy or a total gastrectomy. So the idea is we must preserve stomach whenever oncologically safe. There was a question in chat box also about the distal and subtotal gastrectomy. So we must preserve stomach whenever it is oncologically safe. And I again will give emphasis on the point, oncologically safe, that means you can get an adequate margins. So distal gastrectomy in a distal or middle third tumor, adequate proximal margin achievable, allows appropriate D2 lymphadenectomy, and definitely it will have a better post-operative nutritional or functional outcomes. A total gastrectomy will be needed where if we cannot get an adequate proximal margin, the disease is extensive, it is multifocus, lentis plastica, or a diffuse type. So we have to choose the minimum extent of gastrectomy that reliably achieves an R0 resection. That should be our aim. Similarly, compared to proximal and total gastrectomy, if you see the previous versions of the Japanese guidelines, there was no concept of proximal gastrectomy, because the problem with proximal gastrectomy was that if you are doing a proximal gastrectomy, you cannot dissect the 4D, 5, and 6 group of lymph nodes. So that was the main point, and the previous versions of the Japanese classification only talk about a distal gastrectomy and a total gastrectomy. But there was enough trials to suggest that in an appropriately selected patient, you can omit dissecting this 4D, 5, and 6 group of lymph nodes, so a proximal gastrectomy becomes a reasonable option. So you will select a proximal gastrectomy in a selective early proximal tumors where you can achieve margins, appropriate nodal clearance is possible, and it will definitely have a less weight loss, better B12 iron and nutrition preservation, and better long-term functional quality of life. If these conditions are not met, obviously you will go for a total gastrectomy in a large locally advanced proximal tumor. Inadequate distal margin. Routine nodal clearance is not possible, especially the patients that I just discussed, or it's a diffuse or a multifocal disease. So proximal gastrectomy is a function preserving operation. It is not a compromise in oncological clearance if done in a select group of patients. So reconstruction following gastrectomy. So after a total gastrectomy, a lot of things can be done. Roux-en-Y esophagojejunostomy, a jejunal pouch, jejunal interposition, or double track reconstruction. But I think majority of the centers are, doing a Roux-en-Y simple esophagojejunostomy, which is preferred. It gives a best reflex control. There are centers who like to add a jejunal pouch. I do not have any experience with jejunal pouch, and we stand as a standard to a Roux-en-Y esophagojejunostomy. Now, after distal gastrectomy, again, multiple options are available for reconstruction. Billroth 1 gastroduodenostomy, Roux-en-Y, Billroth 2, and jejunal interposition. Now, Billroth 1 is an ideal, but the problem is achieving it, because if you resect a sufficient amount of the stomach, it becomes difficult to do a gastroduodenostomy tension-free. So it is physiological, will have a very good results, but doing it becomes a difficult. So majority of us, I think, do a Roux-en-Y gastrojejunostomy, which again gives the best reflux control. After a proximal gastrectomy, again, multiple options are available. You can go for an esophagogastrostomy, which is difficult, again, for the same reason. After doing a proximal gastrectomy, to do a tension-free anastomosis, number one. And the second reason is a very high incidence of bile reflux. So esophagogastrostomy, we never do it, and I think majority of the centers are not doing it. The two things that can be done is a jejunal interposition or double tag reconstruction. I prefer to do a jejunal interposition in this group of patients. So we have to choose reconstruction by reflux control, nutrition, and what you have experience with on rescue strategy that you have. Now the extent of lymphadenectomy. So this is the paper that we published some time back related to the lymphadenectomy issues in gastric cancer. I would request trainees to go through it, where we have adequately defined all these issues and discussed and addressed them. These are the regional lymph nodes, station 1 to 12 and 14V. So coming on to the extent of lymphadenectomy. So D1 is a removal of perigastric lymph nodes only. D2 is D1 plus second tier of lymph nodes along the major gastric vessels. And D3 is when we add more distant nodal stations to D2. So then it becomes a D3. Now coming on to this. Now why D2 lymphadenectomy? So I know the very famous Dutch trial. It started in 90s. The first 5-year results were, there is no benefit of D2 gastrectomy, lymphadenectomy. The 10 years, yes, there can be some benefit. And finally, the 15-year results clearly showed that the D2 lymphadenectomy improves disease control when done safely. So early trials were associated with higher morbidity and mortality because the results were affected by routine splenectomy and pancreatectomy or distal pancreatectomy. So a modified D2 lymphadenectomy, better survival, minimal complications becomes the standard of care. So what we are doing currently is a spleen and pancreas preserving D2 lymphadenectomy performed by trained high volume centers that matters. It's a standard for T2 to T4 lesions and any node positivity, and no routine para-aortic dissection is done. So that is what we do as on today, a standard modified D2 lymphadenectomy. So if you look at total gastrectomy, the number of Dr. Sharda very eloquently described this, the number of stations in total gastrectomy. And as I told very clearly, station 10 and station 14V are not routinely removed in this. If you go to onto distal gastrectomy, obviously you cannot remove the 2 and the 4A. In proximal gastrectomy, the 4D and the 5 and the 6 are not removed. But still it remains D2 gastrectomy. In proximal gastrectomy, if you are leaving them, it will still be labeled as D2 gastrectomy, lymphadenectomy. So lymphadenectomy definition as per the current JGCA guidelines, total gastrectomy D1 1 to 7 and D1 plus is D1 plus 8A 9 11P. Now again, this would be done only in an early gastric cancer. We have discussed this. For anything more than T1 or N plus, you will do a D2 in total gastrectomy, D1 plus 8A 9 11P 11D and 12A. A distal gastrectomy will have, you see, in D1 1 3 4 SB 4D 5 6 and 7. In D1 plus we would add D1 plus 8A and 9, and D2 we would add 8A 9 11P and 12A. And a proximal gastrectomy for D1 would be 1 2 3A 4 SA 4 SB and 5 7. 4D and 5 and 6 obviously cannot be there because you are preserving that. D1 plus you will add 8A 9 and 11P, and for D2 you will add 11D also. So this is the standard that we are following, recommended. Now what is D2 plus? So D2 plus is when we are doing more than what I described for a standard D2 feed. It is not routine. Let me again emphasize, this is not routine. It is to be considered in a very select group of patients. So D2 plus is when you add number 10. So this is a proximal gastric cancer involving the greater curvature. Then you add number 10. 14V you add when it's a distal gastric cancer, particularly with node 6 nodal metastasis, number 6 nodal metastasis. You add 12B, 12P, and 13 when the tumor is invading the duodenum. And the 16, you add the para-aortic in a very, very selective, extensive, in a para-aortic node disease, only after a neoadjuvant chemotherapy. Again, a very select group of patients. Now, coming on to the role of omentectomy in gastric cancer, whether you should do an omental preservation, removing only a 3 centimeter of the omentum, or you should do a complete omentectomy. Now, what the results are saying that, for T1 and T2 tumors, omental preservation is reasonable, and you can, preserve the omentum beyond 3 centimeter from the gastroepiploic arcade. But for all T3, T4 disease, completion omentectomy or a complete omentectomy remains standard as on today. There is a trial already ongoing to see whether the complete omental resection versus a partial in a T3, T4. So results are still awaited. Now coming on to the omental busectomy, something that when I was getting trained, we used to do it. But omental busectomy, this is our own systematic review published, 4 years back. We pulled up all the data from a randomized controlled trials and the non-randomized controlled trials, which has clearly shown that, though the omental busectomy does not increase the post-operative complications, but it does not add to the survival. So a routine omental vasectomy is not done, is not recommended. Maybe in some cases where the lesion is on the posterior surface of the stomach, you may think of doing a omental vasectomy in a select group of patients, but definitely no rule of routine omental vasectomy. Now coming to the minimally invasive gastric cancer surgery, laparoscopy is now oncologically established in an appropriately selected patients. For early gastric cancer, laparoscopic distal gastrectomy is the standard of care. It is being shown in multiple trials. It is equivalent to open surgery in long-term oncological outcomes. Now, when we come to the locally advanced gastric cancer, the laparoscopic surgery is non-inferior. There is a difference. For early gastric cancer, it is as good as open, the trials have shown. We need more evidence to say the same thing in locally advanced. But what we know is definitely not inferior to open surgery. And it has been shown by many trials. Now, coming to the robotic gastrectomy, it is safe and oncologically comparable to laparoscopy. There are potential perioperative advantages, but the only concerns are the higher cost and the limited access. But the essential principles in minimal invasive surgery or gastric cancer surgery remains an experienced surgeon. Adequate lymphadenectomy should never be compromised. R0 resection remains the standard, and the surgeon should never hesitate in converting if the oncological safety is compromised. So minimal invasive surgery should not be equated to less oncological surgery. That remains the principle. Now coming to the ERAS protocols in gastrectomy, as in any other surgery, the ERAS is becoming a norm in gastrectomies. Rehabilitation, nutrition, exercise, abstinence from smoking, alcohol, very, very important. Anesthesia, goal-directed fluid therapy, normotherapy, opioid sparing, no routine NGs, selectively drains, feeding to be started as early as possible, mobilization, and criteria-based discharge. So ERAS has been shown in multiple trials to reduce the length of stay and accelerates the GI recovery without increasing the major complications. That's a very, very important slide that I want all the trainees to understand. You see, you cannot have zero complications. We must aim to reduce complications, but what is very, very important is rescue early. So if you're doing anastomosis, there are chances of anastomotic leak. You need to suspect them early. You see whether it's a duodenal stump or the pancreatic complications. What is very important is to have a rescue system. There should be a daily trigger criteria, rapid access to CT, endoscopy, IR and ICU, standard escalation pathways, mobility reviews focused on process, not in blame. So always remember, the best surgical unit is not the one which claims zero complications. It is the one which recognizes the complications quickly and rescue them early. So that should be the idea. Now, finally, a few words about the stage 4 or metastatic gastric cancer. Does response justify surgery? Regatta trial, upfront reduction gastrectomy, or what we call is a tumor volume reduction gastrectomy, no survival benefit. So please do not resect an asymptomatic primarily simply to reduce the tumor burden. It will not improve survival. Renaissance of FLOT 5 trial, surgery after response to systemic therapy. Again, there is no overall survival benefit for this population. And surgery still carries the meaningful morbidity and mortality. So we have to remember this. So, surgery in this set of patients, even after a very good response, should not become an automatic indication for surgery. All these patients must be discussed in MDT and should be selected for surgery in an MDT room only. And finally, coming to the CRS in HIPEC, especially now we discussed about, the PCI of less than 6C. Again, it is not the standard of care. Evidence largely coming from a non-randomized studies only. Morbidity can be substantial. So it should best be done in trial setting or in an experienced peritoneal surface program centers. PPAC for a palliative setting, there is no doubt that it can be done, but whether it will help the patients, the evidence is still awaited. The last and the most important slide is we should always, as a surgical oncologist, we must always assess our quality of gastric cancer surgery that differentiates us from others. We have to measure the oncological adequacy, not merely that how many surgeries we have done. So in terms of R0 resection, in terms of D2 lymphadenectomy, in terms of nodal quality, in terms of perioperative outcomes, in terms of recovery, care, and pathway and oncological outcomes. So our audit in these terms is very, very important. So again, I reiterate, not only the how many surgeries I have done, but all these points to assess the oncological outcomes. The sky is the limit, and thank you so much again for giving me this opportunity. And I would be very happy, me and I think other experts also, to take any questions if they are there.
Thank you so much, sir, for the excellent talk. We'll quickly go through some of the questions that we have jotted down from YouTube. So there was a comprehensive discussion on gastric outlet obstruction, whether to go with upfront surgery or to proceed with chemoport insertion and neoadjuvant chemotherapy. Suppose there is gastric outlet obstruction with bulky D2 nodes. How do we proceed to answer this question in the exam, Dr. Hemant sir?
Operable gastric outlet obstruction with bulky D2 nodes. How to proceed to answer this in the question? I did not get the question myself.
No. Patient has gastric outlet obstruction, not locally advanced, free from the pancreas, operable, but the D2 nodes are bulky, 2 centimeter nodes around. So how
So
do
basically,
we
it's an
answer
operable
this?
okay,
It's an
gastric outlet
operable,
obstruction.
yes.
Yeah. So the nodes are bulky. So
what is the correct answer to give in exam? Do we pass an NJ, go ahead with chemotherapy?
See, as discussed, see if there is a chance of improving the patient, if the patient's general condition is in line with the fact that the patient can be tolerated, will go for chemo. Or if a stent is placeable, if you can stent the patient and then improve the nutrition, give a perioperative chemo, then fine. Otherwise, you go ahead with the surgery with its with the limitations of the result. Probably, and stent probably would be a good bridge here.
Okay.
Or there are centers which do some surgeries also in terms of doing GJs, but probably the stent is the way forward here if it is stentable.
I would like to answer this question in a way that you see, not every situation you will have an answer in black and white. So these would be areas of gray. So there comes the role of your MDT. So these patients should ideally be discussed in your MDT because there are so many other factors which are very important. The social factors, the financial factors, how much it would be the treatment compliance, the input from the medical oncologist in terms of the toxicity. So I think this question cannot be answered in black and white. This has to be discussed in MDT. This has to be individualized for that specific patient. Both options are there. Either you can go for an upfront surgery, or you can put an NJ, or you can do some kind of a feeding procedure and can give the NACP. So nothing would be, I would say, right or wrong. It has to be individualized for that particular patient.
Got it. Next question for Dr. Meera. Can you please quickly summarize the standard steps for peritoneal fluid cytology collection, whether or not we are going to send that fluid for frozen section and proceed with treatment? Can you please summarize that for us?
First thing, frozen section, no role, because they won't be able to tell you in frozen section about pleural fluid cytology. You have to wait for the final cytopathology report. That will take minimum of 3 days. Then the more amount of fluid you send, the better is the yield. So at least take 200 ml of fluid, put it in the normal saline, put it in the abdomen, wait for some time. Maybe you can have a look at the rest of the peritoneum, small ball and all, and then take the fluid and send it for cytology. If they can do cytocentrifugation, it will be the best.
Great, ma'am.
I think
yeah. Proceeding to the next question, Dr. Pankaj sir, can you enlighten us? Is there any role of routine clearance of lymph nodes around the middle colic vessels in an advanced distal tumor with bulky
I just
level 6
answered.
nodes?
There is no routine. It is not a part of a routine D2 dissection.
Right.
I just answered this question.
Okay. And Dr. Hemant, is there any role of resection in synchronous Krukenberg or in metachronous Krukenberg with long DFI?
synchronous Kuchenberg, I think the diagnosis should most likely be made on imaging. So
Yes.
you will manage it as an advanced gastric cancer or a metastatic gastric cancer. The guideline remains the same. So metachronous, I think, with a long DFI, yes, I mean, debulking probably will help in symptom management, if not in achieving the cure.
Right. Okay, sir. Dr. Meera, the last question is the jejunal transposition, which is done proximal gastrectomy. Is it a free flap? And if yes, then to which vessel?
It is not a free flap. It is an interposition graft. I don't have much experience with it, but I have seen my seniors do it, and they do a reverse jejunal transposition so that it will be antiperistaltic and reflex will be prevented.
Right.
So Dr.
Pankaj sir,
Meera,
do you want to add?
because we do general interposition, so basically you can do it either a double tract where what we do the esophagojejunostomy. So after you do a esophagojejunostomy, after 10 to 15 centimeters, you anastomose with the remaining stomach, distal stomach. This is what we call DTR. What we do is a interposition. So what we do, we take out a segment of the jejunum, anastomoses with the esophagus and the stomach, and then there is a jejunogenual anastomosis. So this is how it is done. You can understand it like you see when you. I hope I'm able to explain that. You take a segment of the jejunum, do a jejunogenual anastomosis, your continuity is maintained, so you have a free jejunum with its mesentery. Now this jejunum is taken up. It is anastomosed with the esophagus and distally with the remaining stomach.
Also known as Merendino procedure.
Yes, also known as Merendino. Correct.
Right. I think great answers for the Q&A from our experts. Sorry to put our examiners on the spot, but these were the questions that we got from the Q&A chat and
no, it's a pleasure.
Srijan,
reminder
actually, this is a learning for thanks to IASO's webinars. It's not just the teachers; it's not just the students. The teachers, the practitioners, everybody is learning quite a bit actually. So and the standard is really very high. And I think IASO leadership and Basotarakam in particular is doing an extremely great job.
Thank you so much, sir. A reminder
Dr. Sharda and Dr. Ashish, you were really very good, and you really did very well. And I would like to congratulate you and all the best wishes for your exams and for your future.
One small tip is you please read the Japanese guidelines and NCCN guidelines in isolation, because they are like Dr. Pankaj Garg said, they are looking at two opposite ends of the spectrum. One believes in absolute surgery, the other believes in absolute perioperative chemo. Right, so each have there is slightly a bit of confusion I felt when it comes to these guidelines getting mixed. So try to understand the concept of each of everyone, because there are two different ways of doing the same particular treatment for a same particular disease. As they say, there are 100 ways to skin a cat. So please read. It is really confusing because the Japanese guidelines say one thing and the NCCN guidelines say exactly the opposite. Okay, I think that should solve your confusion.
Yes, sir.
Okay.
And if you are still not confused, you can go read the ESMO guideline also then.
No, there are actually...
I think thank you so much for the comments, Dr. Hemant, Dr. Pankaj, Dr. Meera. Our reminder from IASO that the IASO NATCON 2026 is at Lucknow this year, 9 to 11th of October. So whoever has not registered for the conference, this is the QR code. The organizing committee is in full flow preparing this academic feast for us. I think, do we have Dr. Narendra Holikal with us? Sir, I think he had some issue. I think on behalf of Dr. Narendra Holikal, ISO secretary, we'll give our thanks to first the examinees for volunteering. It's not easy to come up on the stage, a virtual stage, albeit, and face 3 examiners in front of everyone else. So thank you for volunteering. It's a great start to getting in the habit of facing the microphone and being yourself. Thank you. For our examiners, firstly, Dr. Meera, thanks a lot. for the effort that you've put into preparing these cases. It takes a lot of time for our faculty to do this. We could do it the easier way where the residents come with the cases and do it. But in fact, ISO makes sure that our faculty prepare these various case scenarios so that we can discuss the various types of scenarios that come in our clinical practice, and more cases get discussed, although this is not the way it's done in an exam. So thank you, Dr. Meera, for the effort. Thank you, Dr. Hemant, for the excellent insights and the tips that you have given to our residents today. Lastly, thank you, Dr. Pankaj Garg, for the excellent compilation of the literature that I think is contemporary. I think we had the last gastric cancer update about 2 to 3 years back. So I think all the returning participants of IASO might also find it useful to update themselves with the summary today. Finally, I would like to thank ISO leadership for allowing us this opportunity to conduct this. It's a pleasure for us because it just brings our surgical oncology community together. With that, on behalf of team Basutarkam here with me, Dr. Ziva and Dr. T.S. Rao, we would like to bid you all a very good evening. We meet again on 25th August for ISO Mastery of Surgery, where we'll continue the discussion on the operative aspects of gastric cancers with surgical videos. And then next month, we'll have ISO Masterclass on bone tumors on 15th September. All these are on Tuesdays, 7 p.m. Kindly log in again. See you.